Hi, my name's James, and I've had eating disorders for about 20 years, both anorexia and bulimia. I'm talking about some of my experiences with the hope that they will be useful for you when meeting other patients with eating disorders in clinical settings, which is something that will happen to all of you because many people do have eating disorders, whether or not we know on first glance. So first off, just thinking about emergency settings and medical emergencies in eating disorders. I've had many admissions over the last years, and in particular in the last 2 years, about 20 admissions. And one thing I think that's important to remember is that patients sometimes will look perfectly fine. And it's really important to not use just how somebody looks as a metric for how unwell they might be. I was once very underweight and very visibly, obviously unwell. And actually, some of the times when I've looked completely normal, kind of like I do today, I've had the worst potassium of my life. And so it's really important to remember that people might look well, they might appear to be coping when actually they could be physiologically really, really at risk. So delving a little bit deeper and thinking about what tests you need to do and acting really promptly is so important. It just speaks to the need to take eating disorders really seriously and to think that this is something that you can be responsible for caring for and to not leave it to somebody else, but to actually really take it seriously and act as fast as you can. I think that emergencies are pretty difficult for everybody, including staff, of course, but it's really difficult sometimes for me to have stayed in the environment at all. And so I think it's important to consider how to help people to actually be there and to engage in the care. It might be that patients will be really resistant to having any support, and that's definitely been my case, but it's been for really complex reasons, like finding the environment really overwhelming or not being able to trust the support on offer because of having bad experiences in the past. And I do want to be there, and I have wanted to be there, but sometimes I've needed a little bit of extra support to be there. And that can be really simple things like clear communication, like knowing what will happen next. That's really important to me, partly as an autistic person as well. And not for each time you go in, if you go in several times, for it to be completely different. To be honest, I've often been met with pretty stigmatizing attitudes from some members of staff and been blamed for being in the healthcare setting in the first place and for being in a medical emergency. And I've had things told to me like, you're here because you don't want to get better. Why can't you just X, Y, and Z? And actually, I think that a compassionate approach can really help patients to engage and basic human qualities like sympathy, empathy, and expressing that that it's a difficult situation for the patient as well. I think that if there are family members involved as well, or carers or friends who are with the person, to really get them on side because they can help to support the person to be there too. It's not something that I've had, but I think that it's something I would have appreciated had somebody have been there with me. And I think as well as all the things that I mentioned, taking it seriously, helping somebody to be there rather than blaming them, I think that it's also just important not to make assumptions about people. Really often, I think people have made assumptions about why I'm in A&E and why I'm going through what I'm going through, and that can sometimes be really insensitive or it can just be wrong. And I think that keeping a really open sort of perspective on what causes people to have eating disorders, why somebody might be struggling, I think that can help rather than imposing an understanding on somebody or imposing a set of stereotypes as to what somebody might be like and the reasons why they might be there. I think also that it's important not to assume that other people are involved in somebody's care. Loads of times people have said, oh, well, the eating disorder team will deal with X, Y, and Z. And actually, the eating disorder team either doesn't exist, or I'm not in the eating disorder team, or I might be if I wait for several months, or they might not do this particular medical monitoring that somebody will assume that will be being done. So make inquiries about what's being done, or don't assume that people have support that perhaps they don't, or that if people appear competent, that they can somehow cope with an illness more than if they didn't. I think that these assumptions can be real barriers to people getting care that they need and for them to leave and be safer after entering that environment than they were when they came in. In the end, the times when it's really worked for me have been where I've been treated with respect and with compassion and without judgment and being given clear expectations about what's going to happen and when, and being met with human kindness, I suppose, and not feeling like I have to really struggle more than I already am struggling with my illness to get help for the illness, and I don't have to educate people to help me. It's important that I share what's going on for me, but it's really difficult when you're unwell to have to then educate and advocate for yourself. And picking up some of that work for the person who's struggling can really, really help them to have what is ultimately life saving treatment.